Welcome to this series of 2 video casts. I'm Dr. J. Thomas Murphy at the University of Kentucky, and this first video cast will be on the basic management of perioperative pacemakers. The medical knowledge expected to be gained from this series of video casts is outlined in the revised April 2018 content outline. Various types of cardiac pacing, including biventricular synchronized pacing. There is a standard nomenclature which we will cover in this podcast. In addition, you should study perioperative dysrhythmias, which will be the topic of a different podcast and/or PBLD. And you should study the perioperative implications of pacemakers and AICDs, also known as CIEDs or cardiac implantable electronic devices. Ventricular synchronization appears a second time in this outline, so it must be important. You will need to self-study about cardiac ablation therapy and maze surgery, not covered in this podcast. For ablations, cryotherapy, and maze procedure, I suggest you review the PowerPoint by Dr. Peter Jessel from Oregon Health and Science University, which is linked to this podcast on our wiki. Another resource is a 2012 refresher course lecture by Dr. Mahajan at UCLA, which will also be linked to this podcast. After reviewing those 2 references, you will have a much better idea about anesthesia for cardiac electrophysiology procedures. Regarding maze procedure, I will direct you to a brief overview of surgery for atrial fibrillation by Dr. James Cox. The Cox maze procedure has ultimately evolved into the Cox Maze 4, and now there are totally thoracoscopic maze procedures. Anesthesia for bilateral VATS procedures not currently being performed at UK can also be challenging, and I will post a 4th article on this. The learning objectives of this podcast, or this pair of podcasts, are for you to become aware of ASA practice advisories on CIEDs, to develop a preoperative CIED management protocol for your practice, to explain safe intraoperative management of patients with CIEDs to perioperative personnel, to formulate a plan for safe postoperative management of patients with CIEDs, and to discuss the benefits of cardiac resynchronization therapy. This is one of the primary references as suggested by Dr. Schell for this series, and you can access it online. There are also fairly recent practice advisories on this topic, and this is the front page of one from the American Society of Anesthesiologists. Prior to the 2011 practice advisory, there was a practice advisory published in 2005, and you should review the 2011 practice advisory, although I will make reference to it. In addition, the 7th edition of Miller's Anesthesia, Chapter 43, which is quite easily accessible to you, has 10 preoperative key points. Whether or not you get very much cooperation from cardiology, the vendor of the CIED, or your hospital, these are the recommendations for cardiac implantable electronic devices. Product-specific recommendations can actually be quite detailed, and your best resource may be the vendor. In addition, there are a few key points for the intraoperative and postoperative periods. I particularly like the advice to limit the periods of asystole. Patients with disabled defibrillation function must be monitored until that function is restored. The issue of reinterrogation after surgery is a logistical one, and surprisingly, or not surprisingly I should say, vendors who believe that their CIED is immune to interference or inadvertent reprogramming will tell you that interrogation after surgery is not necessary. This is a 2013 review on the topic, also authored or co-authored by Dr. Mark Rosner. And in it, the key points are that there should be a systems-based approach to care. Before elective surgery, the CIED should be interrogated. If EMI is likely, the anti-tachycardic function should be disabled and defibrillator pads should be applied. The magnet behavior of the CIED should be known. There should be continuous cardiac monitoring until the ICD is turned back on or reactivated. There should be documentation of interrogation and programming. And the final key point is that postoperatively, CIEDs often require reinterrogation after surgery. This is a practice guideline from the cardiology literature. A quick search of this document for the word anesthesia finds no hits. These guidelines are for cardiologists. You can use them as a resource, but they do not advise perioperative management of these devices. However, the management of these devices in the perioperative period has been written about in the Anesthesia Patient Safety Foundation newsletter. And this is the fall 2013 issue, and therefore includes the recommendations of the 2011 practice advisory. This slide lists the essential information to be communicated to the perioperative team by the CIED specialty team. This assumes that your hospital or pre-op clinic has a functional CIED specialty team. In many anesthesiologists' eyes, number 11 is the most important one, and the question of pacemaker dependency appears to mean different things to different people. The report that a patient is dependent on the pacemaker when it has been set to a rate of 70 does not necessarily mean that the patient is dependent on it. This is another screenshot from this newsletter, and the box outlined in red may be as important as anything else in the newsletter and refers to the institution having a team. If the institution does not have a team, the editors suggest that the anesthesia providers should rely on the communication with available cardiologists, surgeons, and vendors. And now for something completely different: cardiac resynchronization. Those cardiology guidelines do have recommendations for cardiac resynchronization, and since it figured fairly prominently in our content outline, I will spend a few minutes discussing it. Cardiac resynchronization is a topic which has been covered in the anesthesiology literature. This is an AP chest radiograph of a patient with a biventricular pacing device. And as you can see, in addition to the generator, the can, there are 3 pacing leads located in the right atrium, the coronary sinus, and the right ventricle. So it's not too complicated, and this photograph comes from a review article or chapter in a book edited by Dr. Fleischer in the Evidence-Based Practice of Anesthesiology. And if you take the time to carefully read the details of this slide, you will get an appreciation for the complexity of this kind of pacing. Nonetheless, it does appear to be a successful strategy for improving the function of the failing ventricle in some patients. And the next 2 slides show that cardiac resynchronization therapy can successfully reduce left ventricular volume. So in summary, cardiac resynchronization therapy is felt to be a valuable modality that allows optimization of ventricular function in patients with heart failure and electrical conduction delays. And the benefits of resynchronization therapy are felt to be well established. And improved understanding of these devices and the principles behind the therapy will aid practitioners in caring for patients with heart failure, and this should include anesthesiologists in this day and age. The next 3 slides are from 2016, and it is still purported that CIEDs improve the quality of life in heart failure, and that CRT can reverse the pathologic remodeling of the left ventricle. Here's an algorithm for CIED or CRT use in heart failure. I am particularly impressed by the phrase heart replacement therapy, which is in the lower left corner. In summary, this article from this year does conclude that much work still needs to be done on exploring the benefits of individualized programming and understanding the interactions of these devices in this expanding cohort of patients. This recent article will give you a taste of where CRT is in this year, 2018, and I must say it is even more complicated than before. The essence of this conclusion from the article on the previous slide is that cardiac resynchronization therapy is still in evolution, and probably more patients with heart failure could benefit from it. Moving along into Canada, the Canadian Journal of Anesthesiologists has published its society position statement on the perioperative management of patients with these devices and others. They are not quite as detailed as the ASA practice advisory, but does recommend that planning for perioperative device management should be performed, and it should be a collaborative process. While they're not as extensive or as detailed as the ASA, they do have some practical recommendations, and they do recommend close clinical monitoring. One component of the Canadian Society position statement is somewhat unique in that it refers specifically to the argon beam coagulator, with essentially the same warnings and advice as ordinary electrosurgical devices. In addition to Canadian and American guidelines, there are European guidelines. For what it's worth, a worldwide trial found no MRI-related complications. And further, for your interest, this is the European algorithm for CIEDs, which is a lot more liberal than our local practice. This set of guidelines from Europe has the unfortunate history of having been authored by a discredited researcher, and therefore probably carries very little weight any longer. So what are the key points of this podcast? Well, first, CIED is a relatively new acronym and stands for Cardiac Implantable Electronic Device. Preoperative evaluation, the questions to ask include, does the patient have a CIED? Not every device which is implanted in the delta pectoral area is a cardiac device. So therefore, a focused history, physical, chest x-ray, and electrocardiogram are required. Each one of these will give you important information, including the symptoms that the patient had requiring the device, the location of the device, the number of leads, and a clue as to what kind of device it is, and perhaps the function of the pacemaker or device. So if yes, and the patient does have a CIED, the next questions and key points are, what kind of device? What does the manufacturer's card say? Is there any information in databases, and or can you consult with a cardiologist or the referring cardiologist? If there is a device, you need to determine whether or not the patient is dependent on it. This may require a programmer which will allow you to reduce the rate until spontaneous cardiac activity becomes evident, although it is possible to diagnose pacemaker dependence or the likely dependence by history. And this slide lists a verbal history of bradyarrhythmia, or the history of successful AV nodal ablation requiring a CIED, as being evidence of dependence on a CIED. Next, in the preoperative preparation, a key point is, will electromagnetic interference occur during the procedure? This includes electrocautery, radiofrequency ablation, MRI, and presumably argon beam coagulation. If yes, it is recommended that the pacing function of the CIED should be changed to an asynchronous pacing mode. If an ICD is disabled with unchanged pacing function, the representative of the manufacturer may recommend a magnet. This is at odds with ASA recommendations. If the pacer is not inhibited, presumably it would be safe to keep it in DDD mode. However, if it is inhibited and the underlying rhythm is inadequate, then reprogramming should have been done. Typically, an AICD with a magnet applied continues with unchanged pacemaker function. So, placing a magnet on the device may only disable the defibrillation function. However, the actual practice advisory states that the consultants and Heart Rhythm Society members are less likely to agree with reprogramming to an asynchronous mode. However, the ASA practice advisory and the experts are quite clear on the recommendations, which is to program the device to asynchronous mode, perhaps at a higher rate. Let's talk about preoperative preparation. The ICD anti-tachyarrhythmic function should be suspended. When that occurs, temporary pacing and defibrillation equipment should be immediately available before, during, and after a surgical procedure. Consultation with a cardiologist or a pacemaker ICD service may be necessary. For all CIEDs, consider advising the individual performing the procedure to use bipolar or ultrasonic scalpel. The purpose of this slide is to reinforce the knowledge that not all pacemakers are converted to an asynchronous mode with magnet placement. And the task force recommends against the routine use of a magnet over an ICD. And this is because not all pacemakers convert to an asynchronous mode with magnet placement. The intraoperative management. Primarily, we're monitoring the CIED and its function or non-function or malfunction, as well as the patient. We are trying to prevent potential CIED malfunction. We are there to perform emergency defibrillation, cardioversion, or heart rate support. As part of this effort, our monitoring of the pulse can include an arterial line or a pulse oximeter, or perhaps something as simple as a finger on the pulse. All these recommendations apply to general anesthesia, regional anesthesia, and monitored anesthesia care. Most importantly, if an unanticipated device interaction is found, you may have to consider discontinuation of the procedure until the source of interference can be eliminated or managed. This is most important. Any anesthetic technique is acceptable. To reiterate the guidelines regarding MRI in the United States, American guidelines recommend against MRI in patients with CIEDs except under extreme circumstances. For what it's worth, the majority of consultants, ASA members, and Heart Rhythm Society members generally agree that MRI is contraindicated in all CIED patients. Managing electromagnetic interference. The cautery tool and current return pad should be positioned to avoid current passing through the CID. However, there's insufficient literature to support this statement. Using short, intermittent, and irregular bursts at the lowest feasible energy levels is recommended. Using bipolar electrocautery or ultrasonic scalpel harmonic systems is also recommended. Now, it is stated that radiation therapy is safe if it's outside the field of radiation, and for some reason the topic of runaway pacemaker is mentioned here. Moving on to patients undergoing ECT. ECT can be administered to CIED patients without significant damage to the disabled CIED. No problem here, except that the CIED is disabled, which doesn't sound good to me. But I would be a little worried about the disabled CIED. So, overall, patients with CIEDs who are undergoing ECT require a plan, and it could possibly even require a temporary pacemaker. The next 3 slides summarize what to do for ECT patients. The CIED may need to be placed in an asynchronous mode to avoid myopotential inhibition. Now, as far as emergency defibrillation or cardioversion is concerned, first, eliminate the EMI. Second, you may consider removing the magnet to enable the antitachycardic therapies. Third, you could reprogram the ICD, although if it's an emergency, it may be most appropriate to proceed with emergency external defibrillation or cardioversion. For intraoperative management of ventricular fibrillation or the need for cardioversion for atrial fibrillation, you should follow the ACLS guidelines for energy level and paddle placement. Postoperatively, primarily this is the interrogation and restoring of CIED functions. The cardiac rate and rhythm must be monitored continuously postoperatively. It should be interrogated, and if the settings are inappropriate, then it should be reprogrammed. For an ICD, the antitachycardic therapies should be restored. And all other settings of the CID should be checked to be appropriate. ICDs are CIEDs per the 2011 Practice Advisory. Therefore, the recommendations are generalized for all CIEDs and specific for ICDs where emergency defibrillation or cardioversion are concern. Magnets are a potential problem, and often we have no idea what is recommended for a given CID. To be brief, the behavior of an ICD after application of a magnet is variable. Most devices will suspend the tachydysrhythmia detection and therefore therapy, however. In general, magnets will not affect the ICD antibradycardic pacing mode. And finally, at the end of this podcast, I'm summarizing the advice of the expert Dr. Mark Rosner that no special monitoring is required because of the ICD per se. ECG monitoring and emergency cardioversion and defibrillation must be available. It is his opinion and the recommendation of the ASA practice advisory that every ICD should undergo preoperative interrogation, and that postoperatively the ICD must be reinterrogated and re-enabled because deaths from failure to re-enable ICDs have been reported. The most recent update I can find regarding perioperative management of pacemakers is on Up to Date, and the link on this slide will take you there. So after watching this video cast, I recommend that you click onto Up to Date and review the recommendations that they currently make. They are excellent. This is the end of the first podcast. Thank you very much.